afternoon. You are welcome to leave your cameras on if you'd like, and Jen has just reminded me that we will record the session so that we provide it to people who may not be able to attend today. That's the beauty of online forums, isn't it? So before we get into this session, I just wanted to remind everybody that the Bristol Research Forum on Ageing is a partnership between Age UK Bristol, Brunel Care, the University of the West of England in Bristol, and the University of Bristol. We organise these events three times a year to bring you the latest research on a range of topics related to ageing and older persons' experience. Our last one in December was the first one we had in person since before the pandemic, so that was really lovely, and that was held at the Bristol Robotics Lab on the UE site. The next forum is scheduled to be again an in-person event in June, and I'll come to that later on. So today's topic was suggested by one of our audience members from our last session, and today we're going to hear from two researchers on the topic of autism and older adults, which is extremely timely as it is apparently Autism Awareness Week this week. So our first speaker is Dr. Rebecca Charlton. Dr. Charlton is a reader in psychology at Goldsmiths University in London and leads the Gold Age Lab. Her research focuses on changes in later life and the factors that promote healthy ageing. Her research examines cognition, social cognition, and mood in later life. Her work also examines how ageing affects autistic adults in terms of both cognition and well-being. Rebecca's presentation is entitled The Importance of Age and Age of Diagnosis Across Adulthood. So I'll now hand over to Rebecca to hear more about her work.
Thank you, Emily. So I'll share my slides if I may. All right, can everybody see that okay?
Yeah.
Yeah, awesome. Thanks, Paul. Okay, so thanks, Emily. As Emily said, my research is in ageing, but more recently we've been looking at how ageing affects autistic people. And I'm going to talk to you today about the importance of age of diagnosis, but also thinking about, sorry, slide's not moving, about some issues around health and health inequalities. But I'm going to start by giving a little bit of a background about what we do and don't know about ageing for autistic people and why it's important. So many of you will know that autism is a highly heritable neurodevelopmental condition. It's thought to affect about 1% of the population, but some statistics have put that rate at much higher, at about 3% of the population. And autism is characterized by social communication difficulties and repetitive behaviors and restricted interests. But importantly, it's a lifelong condition. So although it's usually diagnosed in childhood, it is, it's a lifelong condition. And so what do we know about autism across the lifespan? Well, we actually know relatively little about later life. So this is a paper by David Mason and Gavin Stewart and colleagues a few years ago. And you can see that almost all of the research on autism has been conducted in early life, in childhood. And of course, that makes sense because a lot of the early work is focused on childhood and getting children diagnoses and dealing with schooling and things like that. But it does mean that this older age bar here is incredibly small. And so we see that we only have about 100 papers that have looked at what happens to autistic people as they get older. So why do we know so little about autistic older people? Well, there are a number of reasons for this. Firstly, the autism diagnostic criteria have changed a lot over time, and there may be some differences in who receives a diagnosis. But also, if we think about when autism was first formally identified, it's only really identified in the 1940s. So those first identified children are now in their 80s. But autism was only a separate diagnostic category in DSM-3, which was in 1980. So those people are only now in their 40s. So it's hardly surprising that we know relatively little about aging and autism. And so there are a number of barriers to older age research with autistic people, including the fact that autism is a very heterogeneous condition. There are lots of differences between people. There are lots of co-occurring conditions which maybe have an effect. We know that those early descriptions of autism were often based mostly on boys and males rather than girls and females. And there's been a real focus on child development. And while that makes sense, it does mean that the rest of the lifespan is being somewhat neglected. And so why is it important? Well, we have an aging population worldwide anyway. So if you think that there are about 962 million people in the world who are aged over 60, even if we take a conservative estimate of 1% of the population being autistic, that means that over 9 million autistic people are over 60. And we know relatively little about them. So it's really important that we try and understand what the trajectory might be for autistic people as they get older, but also if there are risks that we need to try and target. And one of the reasons why aging is particularly important is that we know that as we get older, we have a lot of increased risk. So we have an increased risk of physical health problems that can lead to increased dependence and difficulty in needing extra support. Mental health difficulties can increase as we get older. So you often see an increase in late life depression with age. And our cognitive abilities get worse too. So we tend to have more difficulties with executive function, so with planning and organizing information, but also with processing information quickly. And all of those things are risk factors for dementia and for further decline. And there have been a number of changes with quality of life that tend to occur as we get older as well. So because of that, because of those general age-related concerns, there may be a risk that autistic people may be susceptible even more so to some of these risks as they get older. But we really just don't have that information yet to be certain whether or not aging with autism is going to be a risk or not. And Francesca is going to talk a little bit more about that when she comes to her presentation. So that's a little bit of background. And so now I'd like to go on and talk about age of diagnosis and why this might be important for aging and autism work. So we know that earlier autism diagnosis is associated with better cognitive and adaptive functioning. And you'll notice these little flags in the corner of my slides, and I put those on so that you know the country where some of this research has been done, because there are, of course, differences across different countries in terms of how people access diagnoses and how people access care and professional services. So it's just worth having that in mind as we go forward. So early autism diagnosis is associated with better adaptive functioning, and the converse of that is that actually later diagnosis is associated with more co-occurring mental health difficulties, greater risk for self-harm, and poor overall psychosocial outcomes. So there really does seem to be an elevated risk for a late diagnosis. And so who is it who's at risk for having a later diagnosis? Well, research so far seems to suggest that females, so girls and women, compared to boys and men, tend to be diagnosed later. People from different ethnic minorities tend to be diagnosed later than white people. And children from lower socioeconomic status are later diagnosed than children from higher socioeconomic statuses. Now, the other difference is that people without co-occurring conditions tend to be diagnosed later. Now, that might seem a little counterintuitive, but I think the reason for this is probably related to the fact that if you have other things, other concerns, perhaps you're more likely to be referred to a clinician earlier on. So people with co-occurring conditions are tending to get earlier diagnoses compared to those without. And so I've said that there are these risk factors associated with late diagnosis, but I just want to talk to you a little bit about some research that goes on to show that. So this is some work from Goldine McQuaid and Greg Wallace and Nancy Ritano-Lee in the US. And this is data from the SPARCS data set. So this is a large data service where autistic people can register to told about research studies that are going on and then invited to take part. And then they choose whether or not to take part in each of the research studies that occurs. And so this is from data that was collected just before the COVID pandemic. And it's in 600 autistic people aged between 18 and 50 who told us themselves about their age of diagnosis, how they were diagnosed, and also some issues around mood and stress. And so this is all self-report data from individuals themselves. And what we see, first of all, is that there's quite a wide range of diagnoses by age. So we are getting people diagnosed early in childhood in this sample, but actually the mean age of diagnosis is 22. And you can see that there are some people here who were diagnosed relatively recently, considering this is a sample up to people who are age 50. And what Goldie McQuaid found was that when we look at age of diagnosis, there's a highly significant association between how old you are when you're diagnosed and how likely it is that you'll report difficulties with depression, anxiety, and stress. So the older you are at diagnosis, the more you report these difficulties. And this remains true even when we account for sex assigned at birth and current age. So even when you take how old people are now into account, age of diagnosis is still important for predicting increased risk of reporting depressive symptomatology and anxiety symptomatology and stress. And so that's some of the risks associated with age of diagnosis. But I think one of the important things to think about then is, well, how many people are and aren't diagnosed. That last study was in people with a diagnosis. But we actually know that rates of diagnosis for autistic people who are older are much lower than we would expect them to be. And so this is from a study that Liz O'Nions did, which Frankie and I were both involved with, which has been looking at GP health records in order to estimate how many people may be underdiagnosed in these different age ranges. Now, what this study shows is that actually, especially in adulthood, but in midlife and later life particularly, there are very much underrepresented numbers of people who should be diagnosed. So it's estimated that between about 500,000 and about 1.4 million autistic people who should have a diagnosis don't. So that's the lower and the upper bounds of that. So even if we take that lower bounds, that suggests that about half of autistic people don't have a diagnosis, which is really concerning about when we think about our research and how we're learning more about autistic people as they get older. And it suggests that only about 3 to 7% of autistic people aged over 50 actually have a diagnosis who should have one. And so you can see these lower and upper estimates of undiagnosed people by age for males and females. And we really are talking about large numbers of older people who don't have a diagnosis who probably should. So later age of autism diagnosis is associated with detrimental impact on mental health. And we know that these diagnostic rates are low, especially among middle-aged and older people. And that really, I think, underscores the importance of timely diagnoses for adults and for young people, but then as we move forward, for people who haven't got a diagnosis early in life, but also that we need to support people when they are receiving those late diagnoses and make sure that we're supporting any co-occurring conditions that may be present. So I want to just sort of finish off by talking about physical health and health problems as people get older. We know that autistic people tend to experience more health problems compared to non-autistic people. Autistic people are more likely to use emergency services and emergency care than non-autistic people. And the estimate is that autistic people tend to die on average 16 years earlier than the general population. So right across the lifespan, you can see, and this is autistic people in the blue line and non-autistic people in the red line, that you can see that there are higher rates of physical health problems really right across the lifespan. And in a number of studies, predominantly from the US, people have looked at the rates of different physical health conditions comparing autistic and non-autistic people, often in terms of access to healthcare or health insurance. But what you can see here is that wherever there's a plus sign, it means autistic people have higher rates of these conditions compared to non-autistic people. And you can see that although not every study looked at every health condition, that there is a real sense that there's an increased risk of these physical health conditions among autistic people. Now, I just want to talk to you about some research that I've done quite recently looking at cardiovascular risk factors and cardiovascular health in autistic older people. So this is a study that used that same Spark data set, but a slightly different age range. So these are people aged between 40 and 83, so that real midlife and older age. And we were interested in looking at the rates of these cardiovascular risk factors because we know they're very important for a risk of stroke and therefore risk of certain types of dementia. And we just look very simply at, first of all, the number of cardiovascular risk factors that people had. So most people had at least one, if not more, cardiovascular risk factors. Only 11% of this sample didn't have any risk factors at all. And about a quarter of the sample had 1, 2, or 3 cardiovascular risk factors. So these are quite high rates of risk for illnesses. And when we compare the presence of these risk factors compared to the general US population, we can see that in this sample, we have higher rates of obesity among the autistic people than the general population, and very much higher rates of high cholesterol and slightly higher rates of diabetes. So the only risk factor here, which is lower or at least similar in the autistic population compared to the US general population, is in hypertension, so in high blood pressure. So this really suggests that there are some real areas of concern around physical health conditions for autistic people in midlife and later on. And so we really don't quite understand yet why there are these health inequalities. It's been suggested that one of the reasons may be that it's related to a minority status. So generally minority status groups tend to have poorer health. There are obviously differences in different countries about how people access healthcare and health insurance, and that may play a role in some of these conditions and how people can easily access preventative treatment. But I think in addition, there's also autistic people often report negative interactions with healthcare providers. So does that mean it's less likely that somebody might go to their doctor in the early stages when you might have treatment to prevent one of these conditions developing? And there may be communication differences or differences in how physical health conditions are expressed for autistic people. So the symptoms they describe to their doctor may actually not necessarily follow the same pattern as doctors are used to hearing or seeing. So there's definitely some concerns there around communication. And that may tie in with some of those sensory differences that autistic people often report. And of course, there is also the great risk of lifelong stressors having an effect on physical health. And that may be particularly risky for autistic people. So I think there's growing awareness in physical health research that autistic people are experiencing high rates of these physical health problems, and these are likely to have an impact on well-being and longevity. We don't really understand all of the reasons for this, but it's really important to try and focus on how we can make a difference and how that we can take that knowledge and then apply it in the real world to actually maybe have an effect on autistic people's physical health. So just to sum up what I've been talking about, research into how aging across adulthood impacts autistic people is really still in its fairly early stages, and there's a lot we really don't know yet. I think there's a real need for this research to actually have an impact on people's everyday lives and to really make a difference to people's health and well-being. And we know that there are similarities in the experiences of autistic people and non-autistic people, but there may be also some subtle differences that need to be paid attention to. And I think we really need to be very aware of these health inequalities and how we can target them and impact them in order to have a real impact for autistic older people's health. So thank you very much for your attention, and thanks to everyone who takes part in our research studies and my colleagues and collaborators. Thank you.
Thank you, Rebecca, for that. that was really fascinating, really interesting. I have to say I know very little about autism, so it's been lovely to hear, sort of get an introduction into some of the difficulties that people face, and the work that you've been doing to try and see where we might be able to start supporting people in these areas. So thank you. I can see there are people sort of writing in the chat, so that's great. Thank you very much. Keep the questions coming for Rebecca and for Francesca, and we'll get to them at the end of the session. So I want to now introduce our next presenter, who is Professor Francesca Happe. Professor Happe is Professor of Cognitive Neuroscience at the Institute of Psychiatry, Psychology and Neuroscience at King's College London, and leads the Respect Lab. She's worked in the field of autism for over 30 years, with a recent focus on under-researched groups, including older adults on the spectrum. Francesca's presentation is entitled Categorical and Dimensional Approaches to the Study of Aging on the Autism Spectrum. I'll hand over now to Francesca to hear more about her work.
Thanks very much, Emily, and thanks for inviting us today. I'll try and share my screen and hope that works. Does that look about right? If we start from, oops, and this is where the panel at the top hides the things I need to do.
Oh yeah,
okay.
We can see it at the moment.
Okay, does that look right to you?
Yeah, looks right to me. Thank
Fantastic. You. Great. So I'm going to talk about aging on the autism spectrum, taking a dimensional approach for much of the work. And thank you to Rebecca for setting up the introduction so briefly. So Hilda Gertz, who's maybe one of the main players in the area of autism and aging, has suggested that there are 3 possible trajectories that we might find when we look longitudinally at what happens to older autistic people. And she's talked about these as being a parallel development hypothesis, where maybe there are some things where autistic people start at a disadvantage, maybe in physical health, for example, and continue to deteriorate in old age, but in a parallel trajectory to typical development. The double jeopardy hypothesis, where they may start at a disadvantage in some areas, but also decline faster with age. And then the possibility of what's been called the safeguard hypothesis, that although at younger ages, autistic people may have some disadvantages, as neurotypical people age and decline, autistic people perhaps might preserve function in some areas and actually look better off in older age. So those are the sort of logical possibilities, just to frame what I'm going to go on and talk about. So to start with some categorical work, Ezra Zivrali-Yara with myself and Rebecca Charlton did a comparison of older and younger autistic adults to try and fill this big knowledge gap that Rebecca's told you about. So she compared autistic and typically developing people matched for age into younger and older groups. Depressingly for me, the older age group in this and most aging studies is split at age 50. So we've got people over the age of 50 into their 70s in the older group, and people in their 90s, 20s up to their 40s in the younger group. We did our best to match the older and younger for IQ, for SES, and to recruit the older and younger autistic people from similar places. And we're just going to return to that theme of here mental health that Rebecca's already mentioned. These are the rates of passing cutoff on standard measures, so not a diagnosis necessarily, but suggestive of a clinical level of need. And we found that there were high rates of depression and ADHD and OCD in both younger and older groups. The only differences we found were that the younger autistic adults were slightly more often reporting anxiety that passed the cutoff. You can see very high rates in both groups, so 80% in the younger group, almost 60% in the older group. So it's an increase in the younger group, but still not to say that the older group aren't struggling with anxiety. And then somatoform disorders were also more common in the younger group, and eating disorders more common in the younger groups. We also looked at quality of life in older and younger autistic adults, and we found that most aspects of quality of life were self-reported to be worse in autistic people than in neurotypical non-autistic people. And that sadly has been reported across the whole age span, but here for the first time we showed it in older age. There was no age by group effect, except in the case of quality of life around social relationships, where we found that while in neurotypical people, older adults reported poorer quality of social life than younger people, again, replicating what's been reported many times in the general population. Among the autistic adults, the older adults actually reported better social quality of life than the younger autistic adults, which is interesting to speculate about. Is this to do with what some autistic older adults tell us is a lifting of a kind of the pressure, the external neurotypical social pressure to do things like neurotypicals would do, and maybe a sense that you can be more yourself. Whereas in the neurotypicals, the loss of some of your social network is felt very intensely. We also asked the question, what's the best predictor of quality of life in this cross-sectional young-old study? And we found that the best predictor of global quality of life was depression, severity of depression. So not how many autistic symptoms you show, but how depressed you are is really what determines your quality of life. And in the case of social quality of life, it was predicted by some social traits measured by the social relationships, social reciprocity scale, sorry. Ezra also looked at some cognitive features of autism, and I'm going to give you one brief example. So she measured what's been called theory of mind or social cognition, being able to understand intuitively and automatically what somebody else might be thinking or intending. And we used a number of tasks, but I'm showing you here the data from the reading the mind and the eyes test, which Simon Baron-Cohen created. And for those of you who aren't familiar with it, your task is to judge which of those 4 words best fits what the person whose eyes you can see is feeling or experiencing. We found in our old and younger groups that, again, as has been often shown in the literature, older, typically developing neurotypical adults were slightly less good at the eyes task than younger, typically developing participants. And we found that in the young group, the autistic participants were slightly less good than the typically developing participants. But what surprised us was that in the older group, there was no difference between the autistic and the non-autistic older adults. And that in part reflected the fact that among the autistic adults cross-sectionally, there was no decrement with age. So it seemed that the performance on this task remained as good in older age. And again, one can think of possible interesting explanations for this, including that autistic people tell us that trying to understand neurotypicals is like doing mathematics, or maybe it's a kind of brain training in itself, and that how they do that is quite often very conscious effort. So maybe the way that they're doing it is not being as affected by age as the way that neurotypicals are doing it, but it remains to be replicated. Now, Rebecca's already told you that autism is underdiagnosed among older adults. And if most autistic older adults are undiagnosed, then studies that only take diagnosed or clinic samples may not be representative. And this is where a trait-wise or dimensional approach can be really helpful. If we know that most older adults are undiagnosed, we can go and look at people who tell us they have lots of autistic traits, and we won't worry about whether or not they've actually managed to jump all the hurdles to get a diagnosis. We know behaviorally and genetically that autism lies on the extreme of a dimension or constellation of traits. There's no blue sky between people who have high autistic traits and people who have diagnosed autism, and that's true both genetically and in terms of behavioral measurement. But I note that there have been recent criticisms of taking this dimensional trait-wise approach. And I agree that not everyone who says, for example, that they struggle socially is struggling socially for reasons of autism. There are other reasons as well. So we have to have a bit of a nuanced approach to measuring autistic traits. So most of the rest of the work I'm going to tell you about was conducted by Gavin Stewart, who was a wonderful PhD student with Rebecca and myself. And he worked with data from an ongoing study called PROTECT. And PROTECT is a study of healthy aging, where participants over the age of 50 who don't at that stage have dementia take part in lots of questionnaires and cognitive tests on a yearly basis. And so far, over 30,000 adults have taken part in PROTECT. And as I said, a broad range of information has been collected. We were lucky that we were able to put into the PROTECT battery a short screener for autistic traits. And any of you who've collaborated with these very large studies will know you can never put in the nice long measure you want. You only get to put in a few questions. So the questions we put in, we asked, as a child, did you struggle compared to your peers, socially or school, with knowing how to get along with other children and understanding other kids' jokes, sarcasm, or deception, sorry. And we asked about current traits. Do you currently find it more difficult than other people to make and keep friends, to understand other people's perspectives, and to recognize if someone means something different from what they're saying? And we counted as a high autistic traits group those who endorsed both childhood traits and at least 2 of the 3 current adulthood traits. We did validate this in a separate sample, and we found that it operates very well compared to standard measures of autistic traits, such as the autism quotient, and had quite good specificity and sensitivity. So I'm going to tell you about the demographics, and for the different studies within PROTECT I'm going to tell you about that Gavin conducted. These will change a little bit, but they give you a rough idea. So taking that definition of high autism traits, we identified that around 1.4% of all those taking part with data in PROTECT met that criterion, and that was around 300 people. And then we can compare them against individuals who don't endorse any of those autistic traits, comparison adults, and we can match them on age and on sex or gender. And then we can ask various questions about what is it like to be an older adult high in autistic traits. So we started with physical health, mental and physical health, but I'll start with physical health. Now, we anticipated from the data that Rebecca has shown you that we would find that the high autistic trait individuals had a lot more diagnoses of physical ill health, especially related to older age. But in fact, we only found differences for mild cognitive impairment and for arthritic conditions. And you can see the effect sizes there for those of you who are interested. So there was no difference in the total number of co-occurring physical conditions between the autistic high trait and the control older adults. But in terms of psychiatric health, we saw very much what we see within diagnosed autistic samples. So depression, you can see in the red bars are the high autistic trait group. Depression, much more frequent, anxiety, much more frequent, panic attacks, and so on. And again, you can see the effect sizes. And of course, some of our high autistic trait people have got an autism spectrum diagnosis, but most haven't, as we would expect at that age. The high autistic trait adults reported more co-occurring psychiatric conditions, with more than 20% having one and more than just over 20% having 2 of these co-occurring psychiatric conditions. And when we gave questionnaires, so we're not relying now on a clinical diagnosis they've received, but since we know that some of these may be underdiagnosed in autism, reporting your symptoms of depression and anxiety and so on, again, we find these are much higher in the autistic high trait people. And I'll come back to trauma and PTSD later on. So to conclude from that study, autistic high trait high trait adults report more psychiatric but not physical conditions by and large compared to low trait peers. We should note that the PROTECT sample are not population representative. Like most volunteer samples, they're predominantly female, predominantly higher SES, a lot of high levels of education, and they've been screened to exclude dementia, which may again affect some of our findings. We also looked at participants in PROTECT who reported that they had an autistic relative, so perhaps were at higher genetic likelihood of having autism or autistic traits, so genetic links. And we found that those individuals too reported poor mental health, but not poor physical health. And again, that suggests to us that maybe it's something about the lives that autistic people live and the stresses that they're put under that are leading to the physical health conditions, but that there are real genetic links between autistic traits and some aspects of poor mental health. But that's a hypothesis to be tested in the future. I'm next going to talk about trauma in older adults high in autistic traits. And in PROTECT, they use both a childhood trauma screen and an adult trauma screen. And these ask about things like physical neglect. There was nobody there to take me to the doctor. Sexual abuse, emotional abuse, physical abuse, emotional neglect with a question like, I never felt loved. You have to say how strongly you would endorse that or not. And counting as anybody who says that it's somewhat true, because if you say it's somewhat true that somebody sexually molested you, you probably were sexually molested. So taking somewhat true and more severe, we find again, much, much higher rates of childhood trauma among those who endorse high autistic traits, and really alarmingly high rates, for example, of emotional neglect being reported retrospectively about childhood, and high effect sizes for those group differences. In terms of adult trauma screen, we again find higher rates for almost all aspects of adult trauma, apart from physical neglect or financial hardship, but again, sexual abuse, emotional abuse, physical abuse, and emotional neglect, all much higher among those who report high autistic traits. And then perhaps in the context, not surprisingly, PTSD symptoms measured using the PTSD checklist, the PCL, which of course is not a diagnosis, but is indicative of PTSD symptoms. We find again that high autistic trait people endorse these items, such as having repeated disturbing memories, thoughts, or images of a stressful experience, or avoiding activities and situations because they remind you of that experience. These are endorsed at a much higher rate, around 20 to 30% among the high autistic trait people, and at very low rates in the controls. We can categorize those who have very high levels of PTSD symptoms and high levels of adversity by looking at who's at the 99th centile for the whole huge PROTECT cohort data. And that shows that around 10% of the high autistic trait group have high levels of high childhood adversity, high levels of adulthood adversity, and PTSD symptoms at this very high level, compared to only around 1% of the comparison older adults. And we can see an interaction between high or low autistic traits and the experience of adversity when we see PTSD symptoms as the outcome. So of course, if you have more childhood or adulthood adversity, as you can see in the blue bars, and you don't have any autistic traits, it's not a good thing to have high adversity, and you're more likely to have high PTSD symptoms. But look at the red bars. So much higher rates, even with low level of childhood adversity, and a disproportionate effect of adversity for those who report high autistic traits. So having high autistic traits potentially makes you more vulnerable to developing PTSD symptoms if you're exposed to adversity, even compared to other people. And these effects, the main effects and the interactions, remain significant if you control for current depression and anxiety symptoms. And that's important because we know that these high trait individuals are reporting more anxiety and depression. When you're anxious and depressed, you may remember or think about your experiences differently and more negatively, but that can't account for these findings here. So I think these points are ones I've mainly made, except to say that interventions of PTSD may be especially needed for older adults with high autistic traits. And our parallel work with younger autistic adults suggests that autistic people are vulnerable to PTSD symptoms following a wider range of experiences than would traumatize neurotypical people. And I can talk more about that in questions. Just a couple of other analyses from the PROTECT study by Gavin Stewart. This one is about self-harm and suicide. And if this is triggering to you, then there will just be a couple of slides about this, and you may want to mute or step away. In PROTECT, they use the UK Biobank Self-Harm and Suicidality Questionnaire, which asks about experience of self-harm, suicidal thoughts and behaviours, the intention of the behaviours, whether they were suicidal, the frequency of the behaviors, and the types of support that were accessed. It doesn't specify a time frame, so we should consider these to reflect lifetime experiences at any time during your lifetime. So I'm only going to show you one item in terms of self-harm and suicidality, because this is sensitive material and because you can read the paper if you want to, and the same pattern is seen in all items. So this question was, many people have thought that life is not worth living. Have you felt that way? And you can answer no, never, yes, once in the paler bars, or yes, many times in the full bars on my left. And you can see alarmingly that over 70% of the high autistic trait adults reported that they had felt that life was not worth living at least once, and more than 50% had felt that many times. And sadly, the same pattern holds for those other questions about self-harm and suicidality. This is a question about help seeking. So after self-harm, did you seek treatment, hospital treatment, psychiatric treatment? And by and large, these weren't different between our groups, except that the high autistic trait group were more likely to seek specialist help, so psychiatric and GP support specifically, but not different in their support seeking from family and friends, for example. I need to remind you again about the overall limitations of the PROTECT studies, that they are a predominantly female and a highly educated group. It's an online study, so many older adults may find that a barrier to participation, and we are very aware that we're not getting data from the full autism spectrum, including those who are autistic with intellectual disability. And older adults who engage in voluntary medical research tend to be healthy, and the whole of aging research is dogged by this survivor effect that is so difficult to get across and get over. The data discussed today is cross-sectional. It's not possible to infer age-related change from these findings. And very briefly, I want to tell you about one last piece of research around aging, and this is from a population representative cohort, the Dunedin longitudinal cohort, which has studied and followed all the babies born in 1972 to 1973 in Dunedin in New Zealand in one particular maternity hospital. In our study, there were around 900, and they have a really good retention rate. At 45 years, the children were followed up as adults, and we were able for the first time to ask to put an autism trait measure in, the AQ10, autism quotient, 10 item. And there are other variables in there, including, importantly, pace of aging from a whole range of biomarkers, facial age based on people's judgment of photographs of the individuals and their facial age, and health ratings by the self, an informant who knows them well, and the researcher who visited them. And what we found in work reported by David Mason and some of us, autistic traits were associated with faster pace of aging, worse health at age 45, and that was true even when we controlled for sex and for childhood, SES and IQ, which we know are related to pace of aging. So the next question that we're going to investigate is why might autistic traits predict faster aging? And in that paper that's published, we suggest the following factors, which again chime in with what Rebecca was telling you. It may be that some of the genes which predisposed to autism also have an effect on pace of aging. It could be lifestyle factors, that if autistic people are lonely or inactive or unable to afford a good diet because they are underemployed, that may affect their lifelong health and aging. It could be co-occurring conditions such as sleep problems and anxiety that we know may affect aging, or societal factors, because we know that bullying, for example, has lifelong effects in terms of health. And being a stigmatized minority is also not good for your health at any point, and certainly not in aging. So to conclude, aging on the autism spectrum deserves attention. There are challenges, and we need a range of methods, as Rebecca told you. Cross-sectional findings suggest the risk of continued poor mental health into old age, higher rates of trauma, PTSD, and self-harm, faster pace of aging, and worse health in midlife. But the key thing that we need to do is identify and address the mediators of good or poor outcome so we can really intervene there. So just to thank all the research participants and consultants with autism, and those on the autism spectrum and those who are not autistic, and colleagues and students at IOPPN and the funders, and thank you very much for listening. And I will stop sharing my screen and hope that you will have lots of interesting questions. So I think, how do I stop? There we are, stop sharing.
Great. Thank you ever so much, Francesca. That was really interesting and lots of information there. And it's for me, I think it's been really interesting to hear about autism in older adults, because I feel like the conversation is very often around it much more in the younger and children. So it's great to be able to see that this is happening. I think before the session we were talking to Rebecca about how it's sort of only really in the last 10 years that it's sort of coming to the fore, that we're sort of starting to think a little bit more about it in the older population. So thank you. I'm aware that there's been lots of chat in the chat and I think Paul's been taking a look at it and monitoring it. So Paul, have you got any questions you'd like to give to Rebecca and to Francesca?
Sure, there's been some great chat and lots of really helpful exchanges about different studies happening and different researchers at different institutions who are involved in various aspects of research. Rebecca, I don't know if you've had much of a chance to look at some of the earlier comments in relation to your presentation. Were there any particular comments that you wanted to respond to, pick up on?
So I think there's been a little bit of a discussion around the menopause and women getting older. And yes, this is sort of it's an area which a number of people are beginning to do some work in. I think women in general often complain that there isn't actually that much work on the menopause, and there's even less in autistic women, but Rachel Mosley's been doing some great work in that. I think she's continuing to do some research in that area. I'm starting some research in that area. So I think that there really is we're in the very early stages of planning and those kind of research studies around the menopause. And then I think somebody else had said there was another study that might be going on to do with menopause as well. So that's in the chat. So thank you for those who have commented on things that are happening.
And there was a comment, Rebecca, about ACEs and trauma. So by ACEs, adverse childhood experiences.
Yes, I think that there are relatively few studies that have the sample size to really look at how these different things interact together. And I think that that's sort of the benefit of using some of these larger data sets like PROTECT, which has autistic trait measures, because when we look at autism studies, they often have relatively small sample sizes of 100 people, which means it's quite difficult when you start looking at these interactions between multiple different factors. So I think that those sort of both adverse childhood events and trauma probably are going to have an effect on health and on sort of well-being long term, but how that interacts with other factors, we haven't really unpacked yet. And I think that it's really a question about sample size. And some of the work from, say, Hilde Geerts's group in the Netherlands, I mean, she's got data sets of about 500 or 600 people, but that's still relatively small when we have these multiple factors that we have to consider.
Thank you. Francesca, if I can come to your presentation. There was a question from Judith about differences between men and women. And I think this was when you were talking about, it's one of your earlier slides about mental health outcomes, comparing younger and older adults, when you were kind of setting the scene for that background slides. I don't know whether you want to just comment on, are there any noticeable gender differences as people head into middle age and later life?
Well, I mean, I think that in autism we see the current imbalance in eating disorders, which was one of the things that I flagged up. And of course, although men can be affected by eating disorders, it's predominantly women currently who are. And we see in the clinics here at the Moseley Hospital quite a rate of people, particularly with anorexia, coming into the clinics who then meet diagnostic criteria for autism, but weren't diagnosed. And so we think this is diagnostic overshadowing, that clinicians see the eating disorder, but they don't see that it's in the context of autism. And it does seem really important, both for the care pathway and also to understand the drivers of eating disorders, that we recognize that. Now, that hasn't been explored specifically in older women and men, but I was hearing from an eating disorders colleague just the other day that actually hormonal changes at menopause can be a trigger to either a relapse in eating disorders or a worsening of eating disorders. So I think it probably is an important place. Sadly, of course, many people who are badly affected by anorexia, the mortality rate is terrible. So there may not be all that many old people who had severe anorexia, but the link between eating disorders and autism does seem to be really important.
Thank you. I'm just looking through the other questions. There was a question from Sarah about, is there any research being done investigating complex PTSD, post-traumatic stress disorder in autistic people?
Yeah,
so one's been mentioned.
Yes, so we are investigating PTSD. We've recently become aware that complex PTSD is a very important aspect of that. And so we will be broadening our research out into that at the moment. Again, it's not specifically focused on older adults, but in the adult work we've done so far, I think the range definitely includes people in their 60s and 70s. And what we find is that having experienced a trauma, autistic people seem to be more likely than non-autistic people to develop PTSD, and that what counts as a trauma for autistic people is much broader, and it includes things like bullying that in the traditional diagnostic manuals like DSM-5 doesn't count as a trauma. It has to be life-threatening to be a trauma in DSM-5. So we're really worried that autistic people will be denied the diagnosis and therefore the help that they need, at least in the States and places where they use DSM-5 strictly. Luckily in the UK, ICD-10 and 11 don't have such a strict speculation. But yes, we are looking into PTSD.
Fantastic, thank you. And there was a question here that Rebecca and or Francesca, you might want to respond to. Question from Jill about the higher rates of sexual abuse, and kind of thought about, is this due to the risk factor of autistic people potentially not recognizing they're at risk in around perpetrators?
Yeah, I mean, I think that's certainly possible, or sort of misinterpreting certain situations and ending up in scenarios which are dangerous and sort of where harm can take place. That I think that's definitely, I think that sounds very reasonable. Whether or not we have the evidence that that's definitely true, probably not yet. There's a researcher in Australia who has done quite a lot of work looking at trauma and especially sexual abuse in both men and women who are autistic. So there is work in this area, but I think it's still early days.
Yes, I think anecdotally the difficulty is that we don't teach very explicitly what's appropriate and not. And if you aren't getting information from, just chatting with friends, and you maybe, as we know from masking and camouflaging, take what you consider to be right behavior from film or TV, depending on what you're watching, you may be getting a very inappropriate appropriate sense. And of course, autistic people go through life often feeling completely puzzled by the way that neurotypicals organize the world. And it may not seem all that surprising to them, on top of all that some abusive partner says, no, that's what everyone does. You must do that. That's part of being a good partner. So I think there's a real question about vulnerability there. And I see in the chat just briefly that there was somebody else on the call who has expertise in that. So it might be nice to bring in other people or have a more general discussion depending on time.
Did anyone want to comment on this issue? If you could perhaps just use the raise hand function. Okay, I'll move on to, there was a question here about cultural differences. So thinking about people who are from non-Western backgrounds, non-Western worlds, their attitude towards illness and aging, and how those cultural differences might, whether they might have an impact on some of the findings that you've both been speaking to.
Yeah, I think that's a really good question. I think there's I think we're becoming more aware that most research is carried out in Western countries, with most participants being white, middle class, often male. I think this is a real problem for research as a whole, rather than being sort of a problem in autism specifically. But I think that's a very good point. And I think we are slightly stymied by the fact that most research still remains in Western countries, especially in Europe or in the US and Canada. So I think there's a growing awareness that we need to sort of branch out a little bit more. But I'm not aware of a great deal of research which really has done that in a systematic way, especially not in later life. So I think these are the sort of the steps that we need to take. We need to really make sure that that's embedded in our research as we move forward.
And maybe thinking specifically about the topic of aging, it is absolutely a salient point about culture, because I think in this country and in many Western cultures, we really don't value older people. It's real double stigma to be autistic and elderly. And I hope that there are other places around the world where older means wiser and means respected. And it would be really nice to see what happens for older autistic people in those contexts. But as Rebecca said, the difficulty is that in many of those countries, autism is stigmatized and is not being diagnosed, and that certainly to find autistic older adults would be extremely difficult, although we shouldn't give up on the challenge.
Thank you.
I noticed that Sarah's put her hand up.
Yeah.
So did we want to bring Sarah in?
Yeah, Sarah, did you want to speak to the